To start with the session, we are honored to start the session with none other than Professor Dr. Claudio Ronco. I would say the tallest figure in the nephrocritical care arena worldwide. I'm very fortunate to meet him in India and also in his hospital and in his conference, which is world renowned. That is the IRIV conference, and it is again about to be in the month of June end in Vicenza, Italy. Now, Professor Ronco is the most distinguished, I would say, the voices in the nephrocritical care globally. He is the director of the Department of Nephrology and International Renal Research Institute, IRRIV, San Bartolo Hospital, Vicenza, Italy. He is also the organizing chairman of the 43rd Vicenza course, which is about to be in, I think, around 2 months from now, June 24 to 26. Now, he will walk us through the myths, the evolving evidence, and also the future outlook of the extracorporeal therapies in septic AKI. What is right now happening in the world and what is actually in the future. That would be definitely help us define this problem at the current time. So with this, I am handing over to Professor Dr. Ronco.
So thank you very much for inviting me today, and it is a pleasure to virtually meet all of you. Today, as it has been mentioned, is the Labor Day in most of the countries around the world. This is a holiday that was probably started in the 19th century, giving the idea of one day where beyond the classic movement of 8 hours work, 8 hours sleep, and 8 hours to enjoy life, in one day of the year, there should be simply one day for everybody who is working. So my speech today is dedicated to everybody who is in the hospital and is working in this moment. Now, sepsis is a cascade of events and it is a syndrome. And we know very well that from the moment bacteria and endotoxin invade the circulation, there are receptors on the monocytes that activate macrophages and monocytes and indeed lead to the presence of humoral effectors in the blood, leading subsequently to organ damage and failure. Now, this is a very important point to know because the pathophysiology may represent the target for several different therapies. There are survival sepsis campaigns that suggest resuscitation, antibiotics, source control, and organ support. And there are also suggestions to try to achieve immunomodulation by pharmacological approach. However, if we look at the pathways of mediator and sepsis potential treatments over the years, the results of randomized control trials are basically all negative. And if you have initial some positive results, for example, with activated protein C, in general, we're talking about negative results, and negative results. And this is partly due to two reasons that we will see. One is the attempt to block one single pathway while we have multiple pathways in sepsis. The other is to apply the intervention to a general population, which may be composed by different phenotypes. So this is why a time-dependent approach with extracorporeal therapies has gained traction recently. Now, when you look at the most recent approaches, which suggest, for example, the use of hemoabsorption, you have to go back to substance and assumption, which is myths and facts. People look normally for clinical evidence using systematic review and meta-analysis, and then randomized control trial. And the level of evidence from classic to limited goes down as you end up with CAS series and expert opinion. However, the pathophysiological rationale based on the better understanding of the pathways start from initial knowledge, and with new information and animal studies, in vitro studies, and new cases, increase the pathophysiological rationale for therapies. And finally, the clinical experience with the initial success and extended application and increased confidence of certain treatments may become innovative approach and clinically sound approach to the treatment of sepsis. So you see, the clinical expertise, in my view, is at the center of the application that depends on clinical state and circumstances, patient preference in action, and research evidence. However, guidelines are often outdated and their recommendation may often come too late. So we have to consider these approaches. Now, in order to overcome this limit, we have created the so-called Acute Disease Quality Initiative Work Group, and in particular, we looked at the pathophysiology of sepsis-associated AKI. Now, we have defined the fact that in sepsis, there are distinct sepsis-induced AKI endotypes, and you need to identify specific endotypes, possibly to do enrichment in the population for clinical trials. Now, if you look at the sequential integrated approach to sepsis provided by possible extracorporeal therapies, you may start with infection and the presence of pathogen, the presence of endotoxin, the presence of cytokines, and the presence of toxin due to organ failure. This is a time-sensitive effect on the cascade, which may result into ideas to provide specific extracorporeal therapies with elimination of the bacteria, elimination of endotoxin, and subsequently achieving immunomodulation and removing cytokines, and finally providing multiple organ support therapy. We have today sorbents that provide possible removal of viral particles and bacterial particles from the circulation. This is a very interesting approach because in the early phase, you may actually somehow cut down the concentration of circulating viral particles and bacterial particles in the blood. And this is a very potential interesting approach, although it has to be very time specific. Then, when you consider the insult, which may not only include infection in sepsis, but it may also include trauma, tissue necrosis, pancreatitis, and other conditions called cytokine release syndromes and inflammatory syndromes. The presence of pathogen and damage-associated molecular patterns in blood may lead to activation of sensor on the immune cells and prime a series of macrophages that, in presence of a lack of lymphocyte C4, may indeed accumulate, and when C4 populations start to be reconstituted, there is an invasion of primed macrophage cells into the circulation. This leads to activation of very important complex protein system, vascular and access tissue, and blood and lymphatic cells that you see may activate mediators that go from complement, coagulation, endothelial molecules, acute phase reactants, cytokines, and cell surface marker. Now, all these cells may have an impact on different organ systems. The first molecule that is involved in this process, for sure, is endotoxin, also called lipopolysaccharide. And although we know that not in every patient LPS may be high in sepsis, we know that when you have sepsis and you have high endotoxin level, the chance of survival decreases significantly. So here is a series of studies that have been conducted using a very typical and specific extracorporeal technique to remove endotoxin called polymyxin B hemoperfusion, where you basically utilize polystyrenic fibers, modify on the surface with addition of polymyxin B that is very sticky and very capable of removing both in vitro and in vivo significant amount of endotoxin. In our first study on abdominal septic shock patients, we were able to show a significant improvement in SOFA score at 72 hours and improvement at 28-day survival, although the initial design of the study was not with the primary endpoint on survival. The Euphrates trial, while failed the primary endpoint in the general population, has achieved significant interesting results in a modified per protocol population, which is about approximately 200 patients, with an endotoxin activity assay between 0.6 and 0.9. The surface, scratching the surface of the study, you may not see what is inside, which is a difference in survival between the two groups and an increase in hemodynamics and increase in mechanical ventilation free days in the group treated with polymyxin B. So we suggest, as you do for CRRT, when you prescribe 20 milliliters per kilogram per hour and you see the azotemia climbing and you move to 30 milliliters per kilogram per hour, the same is true for endotoxin. When you see the level of endotoxin climbing at a certain point when you hit the threshold of 0.6, that's the moment to start hemoabsorption. But of course, you not always can completely block the pathway of endotoxin. And in this case, you have host-derived primers and biomarkers that are generated specific molecular pathways. And among them, we can include cytokines. At this point, from the endotoxin removal, you have to move to the cytokine removal project. And indeed, you know that when sepsis is occurring, we call this disruption of the immune response due to increased inflammation by the response of the innate immunity. Some patients may die due to intractable inflammation, or even activation of the adaptive immunity, and some patients may actually die because of immunosuppression and recurrent infection. At this point, the idea of removing cytokines may therefore be considered important not as a specific approach, but rather a non-specific approach where pro-inflammatory mediators and anti-inflammatory mediators, whether they occur in subsequent poussée or they are present simultaneously, may lead to a reduction and elimination of the peak of concentration of these substances, reconstituted in part some immunohomeostasis. To remove cytokines, we have different dialytic techniques. One is separation by barrier, and this includes all the typical CRRT techniques. The other is separation by a solid agent, and this includes hemoabsorption. Now, when you use a membrane separation process, there are membranes today that are capable not only of filtration and diffusion, but also to absorb part of the molecules due to surface functionalization, as in the case of oxiris. And you see, for example, that cytokine clearance can increase significantly, although in the dialysate you don't find the substance, which means these are absorbed in the structure of the membrane. But if you look at the molecular weights of the inflammatory molecules and other dumps, you immediately see that these are in a range that cannot be removed either by diffusion or convection. So absorption is definitely required. And today, absorption has the advantages of overcoming the limitation of dialytic therapy, increasing the spectrum of solute removal with various techniques and options. Of course, you need an effective removal of target molecules. The pathophysiological rationale is there. Clinical evidence has to be built, and then you need a stable hemocompatible device without side effects. So here is a spectrum of adsorption devices that are available today on the market. Thanks to special chemistry, recently a neutral macroporous resin has been developed with high properties of biocompatibility and high capacity of removal. And thanks to nanoscale molecular seed control technology, one may adjust pore size distribution so that you can target specific molecular weight toxin. Adsorption dynamics and forces have to be optimized, and van der Waals forces, ionic bonds and hydrophobic bonds, represent the mechanism for solute adsorption. And you can place the sorbent either alone, as in this case, or either before or after the filter in case of associated CRT. Now, we know in vitro the high capacity of this resin to remove cytokines, both in the pro and anti-inflammatory side. And this has led to the discussion of the possible role of extracorporeal therapies in sepsis, right? Now, there are several different theories why this should work. One is the threshold immunomodulation hypothesis, where in spite of clinical effectiveness of extracorporeal therapies, it's likely to be only at the blood level. A possible effect is envisaged at the tissue level. The model, in fact, hypothesized that the mediator removal from blood is coupled with changes in the tissues. The other is also with the possibility to have a secondary removal from the blood compartment to a point where pathways are actually completely shut down and cascades are blocked. At this threshold point, further tissue damage and organ injury is stopped. And the challenge is to apply a therapy where the removal of mediators reach a threshold point at which destructive inflammation is abated at tissue level. Another is the mediator delivery hypothesis, which is considered a kind of washout of the lymphatic system with concomitant drag of mediators from the blood compartment into the blood compartment and subsequent removal. And finally, the peak concentration hypothesis, which is the one I mentioned before, with the removal of peak of concentration of both pro and anti-inflammatory mediators. So basically, the failure due to blockade of one specific molecule with drugs has led to the idea that we might need a magic shield, not a magic bullet, to block a series of specific events occurring in sepsis. And indeed, the ADKI group has produced a consensus statement where extracorporeal blood purification techniques can be used to remove different substances in sepsis, and initiation might be considered for immunomodulatory molecular pattern and pathogen-associated molecular pattern. So, again, in this case, CRRT and hemoabsorption together can actually be applied early and have a rationale for immunomodulation and organ protection with non-specific cytokine blockade and possible endothelial and organ protection. This is what we normally see. In these conditions, patients see reduction in circulating cytokines with no side effects. But there is more. In particular, not only removal of cytokines, not only removal of vasopressor support in presence of an improved hemodynamic response, but also an improved function of the monocytes that start to respond to priming with TNF and with priming with LPS, producing TNF, and also phagocytosis. The pro-apoptogenic potential of plasma is significantly reduced after treatment with hemoperfusion and CRRT, and the capacity of phagocytosis increased dramatically. But also, we have a significant increase in the capability of monocyte to present the antigen, as demonstrated by the increased expression of HLA-DR on the surface of monocytes. So this, for example, is a typical case of a patient with cytokine storm in consequence of COVID-19 situation, admitted with fever and high pro-inflammatory profile, treated for 3 subsequent days with session of hemoabsorption, with a significant normalization of cytokine levels and inflammatory parameters after it was extubated on day 12. So as you can see here, we have a sort of integrated approach to sepsis, which implicates a cascade of events and a cascade of treatments, which is time sensitive to remove first endotoxin, then cytokine, then to protect from organ failure. Of course, when you have a cartridge like this, you have to be aware, and we studied this with absorption isotherms, that approximately after 6, maximum 12 hours, the sorbent saturates and makes no sense to continue the therapy. And in fact, what we propose in these patients is 1 or 2 sessions in the first 24 hours, but no more than 4-6 hours each, with possible sessions in day 2 and day 3. Now, how do we recognize the different substances that we can use? Because the so-called macroporous has a capability to be permeated by blood and macromolecules. And thanks to these studies, new sorbents have been created, in particular this sorbent, that has high capacity for removal of cytokines, but also additional capacity for removal of endotoxin. So in our sequential approach, we may actually use the product that can first remove cytokine and endotoxin, and then the product that can remove cytokines. Again, in the sessions, no more than 4 to 6 hours each, but maybe with different products according to the cascade. Now, it has been published very recently, the concept of subphenotyping the patients in order to do accurate diagnostic and personalized sepsis care. And here you see how you may enrich your trials by analyzing different subphenotypes. Basically, in sepsis, you have to look for phenotypes, but also for endotypes, which describe also the interaction with the pathophysiology and the origin of sepsis. And indeed, only in those conditions where you know that you have high circulatory level of mediators, which may be documented biochemically or may be documented just clinically by the severe vasodilatation. This is the moment in which, when you develop or you start developing AKI, as you can see here, you can apply the strategy described in our paper in Lancet with the blue arrows, which is basically controlling inflammation. This is the best mitigation intervention you can approach for AKI. And indeed, in the hyperdynamic sepsis model of a sepsis-associated AKI, you have almost no creatinine increase at the beginning. You have an increase in renal blood flow and decrease in GFR and urine output, with increase in cytokine that induce vasoplasia. At this point, this is a completely different syndrome from the classic ischemia reperfusion or toxic AKI. It is a syndrome where in the biopsy there are no lesions. There is a system where you see a shunting of flow from the cortex to medulla, and the cytokines that are released may represent a target for therapy. If this is the case, we can provide protection before damage occurs. So once again, endotyping the patients with AKI allow you to suggest which one is the right population for the application of extracorporeal therapy. Not everybody, not every patient should be, but just specific patients. And some questions actually remains for research. What are the biological mechanisms underlying sepsis and critical ill phenotypes? Which are the treatment strategies are most likely to work in each subphenotype? How do subphenotype derived by different groups relate to each other? To what extent do some phenotype critical illness syndromes represent a traitable trait? And How do we best measure the biomarkers needed to assign subphenotypes to a clinical environment? Finally, how is subphenotype information best used and categorical or continuous trait? And can heterogeneity of treatment effect identified post-hoc analysis be validated in prospective randomized trials? So if you look at the different conditions that lead to sepsis and septic shock and septic-associated AKI, in any case, hemoabsorption and CRRT may help somehow cutting the peaks of the mediators, leading to a protection of endothelium with significant hemodynamic improvement, reduction of cytokines, and no side effects. In conclusion, I think the systemic inflammatory syndromes are dangerous and potentially lethal, and adsorption represents an interesting option for blood purification in patients with systemic inflammatory syndrome. Different sorbent materials and devices are available with selective and non-selective properties. Optimal biocompatibility ensures safe and effective application of hemoabsorption techniques, and different options are available for utilization of sorbent in practice. Therefore, sorbent may represent a new frontier in extracorporeal blood purification. But sepsis requires a time-sensitive approach. Endotoxin and cytokines represent possible target molecules for preventive and protective treatment and interventions. Studies should evaluate criteria for initiation and indication, duration for the treatment, clinical and biological endpoints for efficacy measurement. We need to identify patients who possibly benefit from the treatment and prescription and must be made in specific patient early, monitoring inflammation parameters and organ function. Now, with this, I would like to take the liberty to invite you all to our AKI, CRRT, and ECOS conference on critical care nephrology in Vicenza in June 24-26. It's not a long trip to join Vicenza, and you have the possibility to visit Italy also. But the most important thing, you will be in contact with the top expert in the world. We have 60 different faculty members, and we have actually something like more than 80 lectures that are providing information on different topics, including sepsis, sepsis-associated AKI, cardiac surgery. We have transplantation. We have pharmacological approaches and extracorporeal approaches and different organ support therapies and different pathophysiology of AKI. So my suggestion is to join. And as Tapas Kumar Shahu will say, we had also helped the Nephrocritical Care Society offering some special registration for one person for free. And we hope to see, however, many more members to discuss with them this topic, which represents a very crucial aspect for our day-by-day activity in the hospital, but also from the point of view of our society. With this, I thank you very much.
Professor Ronco, there is a question from Indonesia that what is the right time to start this type of therapy? Like any specific indications as for the lab investigation or the clinical situation, anything that you take it as like yes, at this time we should start this?
Yeah, this is a very important question, and I will offer my personal view on this. If this therapy is designed to prevent further derangement of the system and to protect the organs, makes no sense to do it too late. So when we have learned from the beginning with renal replacement therapy that it makes sense to do it quite early to avoid specific complications to develop. In this case, we are preventing some of the pathways and the mechanisms that lead to derangement. So while I understand that it might be little specific and probably too sensitive to begin with the patient with initial oliguria and stage 1 AKI, I may say that when you have this patient and you also have in parallel a decrease in urine output, which is paired by a significant generalized vasodilation, which describes very well the presence of pro-inflammatory mediators in the circulation, this is the moment to start. So I will strongly recommend, if you do any case series studies or if you want to do some experience, please begin early. Then somebody will always tell you, oh, but this patient would have survived anyway. Yes, thank you very much. But how do you know that? So we need to do some studies. But on the other hand, the clinical experience will tell you exactly which are the patients. And we don't have too many patients that actually develop this type of endotype characteristics. So in this patient, I suggest we need to apply the treatment early.
Yeah, thank you. Thank you, Professor Ronco. The last question that I will take, because there are a lot of questions, I would be not able to take all the questions because of the constraint of the time. But one question that is also ringing in my mind also, that is there any current indication of RRT in sepsis related AKI?
I lost your voice. I'm
Yeah,
sorry.
yeah. There is a question in the chat box that what are the current indications for the early versus delayed initiation of RRT
Okay.
in
The
sepsis related AKI?
the indications that are proposed by guidelines like the KDIGO guidelines that were written anyway in 2012, so they are very old. The indication is initiate when it is needed, which is ridiculous, right? So I personally suggest, and this is the scope of a critical care nephrology society, make an alliance in your hospital, nephrology and intensivist, see the patient together, follow the patient, look at the trends rather than the numbers in one specific moment. And when you see the trends deteriorating, start the therapy. Don't wait until the patient is almost gone, because then you will have no results. This is what we can try to do in the concept of subphenotype in the patient, although if we don't have good biomarker for the moment. Generalized vasodilatation, if you have it, high interleukin 6 and other pro-inflammatory profiles, patients that start to have low platelet count and especially significant hemodynamic instability. This is the patient that subsequently develop AKI and you want to try to protect the kidney.